One of the things about the interactive section is that whether you're here in the audience or you are on simulcast, you can text your responses using the 22333 ASTRAC on your cell phone, and we'll get your opinion. I will warn you though about this case, and that is the fact that at the end it doesn't have this like warm conclusion that golly, that's what I'm going to do next time. This is really about how tough pediatric trauma can be. It can also be somewhat entertaining. The pre-hospital report went something like this: ran over by friend while out of car, liver laceration, pulmonary contusion, difficulty breathing. Ran over by friend. Okay. So when the patient gets here, he states something to the nature of, I was holding on to the door handle on the passenger side when my friend pulled away as a prank. And his hand was caught underneath the door handle, and he was pulled under the vehicle and literally run over. On arrival, in transfer from our center, he was alert and talking. He was not, in fact, in any respiratory distress. His heart rate was 104, respiratory rate was 25, his blood pressure was 115/58, satting okay, a little bit of pain. Had some neck tenderness, C-collar was in place, his abdomen was soft, non-tender, normal bowel sounds, tender to palpation in the left upper quadrant, not peritonitis, just hurt when you push on it, and he had abrasions everywhere. My crack nurse practitioners diagrammed his abrasions, and I thought this was worth including to kind of give you a feel for where he was marked up. He had a pretty significant abrasion on his back, which is what we circled there in red. HemQ was 13.1. His FAST was positive. He had some blood. He had some fluid in his abdomen. X-ray showed a right hand metacarpal fracture. CTs of his head and neck at the outside hospital were negative. The uppercuts of the abdomen showed a pulmonary contusion and a pneumomediastinum. His abdomen showed a liver injury, a pancreatic neck contusion, and an adrenal hematoma. So we'll kind of go through that stuff. The pneumomediastinum we see pretty commonly in pediatric trauma centers. And so there was no widening of the mediastinum, no swallowing problems, and no pneumothorax. And this is what a CT scan looked like. So we'll let you look at that, and you see some pulmonary contusion here and a little bit of air there. So the first question, and this is his chest X-ray showing that aside from the pulmonary contusion, doesn't look too bad. Esophagram, CT of the chest, CT-A of the chest, bronchoscopy, or nothing. So who votes for esophagram? Again, no hands. CT of the chest. A couple of those. CT-A of the chest. Got a few of those. Bronchoscopy. A couple of those. Nothing. Lots of nothing. I like that. Well, what we did was nothing. And the reason that what's that? We'll get it for the next one. The reason we did nothing is that there are actually some studies on this, and this study, looking at the National Trauma Database, which I've misspelled, looked at 193 children with pneumomediastinum, and about 8 of those children, or 4%, had life-threatening injuries. But 100% of those patients with life-threatening injuries had other injuries that would have been visible on a plain chest X-ray, and most of those patients also had abnormal vital signs. So what we learned from that is that in kids, if they don't have a widened mediastinum, you don't have to do a big workup for pneumomediastinum, okay? In and of itself, it's not predictive of any of those things that we worry about. Now, we saw on the CT scan, which I'll show you in a second, that the patient had a blunt liver injury and a pancreatic contusion. His heart rate's 104, respiratory rate's 25, blood pressure is still stable. And it's kind of bad. So for those of you who aren't used to looking at CTs, the liver is supposed to be this beautiful gray color with some blood vessels in it. Instead, we have some stuff that's not quite so pretty there. I'll give you a few other cuts to let you see that it's pretty much all the way through. We also have a little bit of this stuff going on where you're not sure if that's in a vessel or not. And down in the pelvis, we see that there's a little bit of fluid, which accounted for our FAST being positive. So, where does the patient go from here? We're going to try? Okay, we're good. Remember, it's 22333, ASTRAC, and then type in the number. Oh, I'm sorry. 2 through, you don't have to type in abstract, just that in the code. Learn something new. So do you go to the operating room? Do you go to the PICU? Do you go to the CT scanner again, the interventional radiology suite, or the endoscopy suite? Now I'll tell you, just if you're not voting because you're not a nurse, that's not how this works. Okay, all right. Everybody votes. We have a lot of votes for taking this patient to the operating room, and a few going to the PICU and a few going to the IR suite. I think we'll cut it off about there. Okay, let's go back. So it looks like OR 1, but that's not what we did. And the reason that's not what we did is that we actually have an algorithm that we use for caring for our patients with blunt liver and blunt spleen injury. And this is the atomic guideline, which is being used by about 11 or 12 pediatric trauma centers now. And basically, the way the algorithm works, because it's a little bit too small to see up on the screen, I'll kind of show you the key part, which is, does the surgeon suspect ongoing or very recent bleeding? And if yes, they get a fluid bolus, and they see if they have a response to the normal saline. Unlike ATLS, we don't do this like 3 times and dilute them out with crystalloid. If one bolus doesn't do it, then they get blood, as you see here on the algorithm. They get some PAC cells. But this patient actually has a HemoQ of 13, isn't hemodynamically unstable, and so they go to the PICU. Now, if they had gotten blood and had stabilized, they would have come here to the PICU. If they had gotten blood and then became unstable again, then they would have failed the algorithm. So that's just kind of a short version of the algorithm. So they went to the PICU. In the PICU, they were hemodynamically stable, heart rate's 100, they've got good perfusion. They've got no appetite though. Hemoglobin checks are Q4 hours, and the hemoglobin checks look kind of like this. Unfortunately, you can see the patient was actually here for a while. They didn't just go home very quickly. And so, these numbers, this is the 13 that he came in with, and what you see is that, he dipped down, he's in the 10 range, and, and so during the early resuscitation period, he's got a pretty good hemoglobin. It's probably good as mine. But then after a few days, he gets jaundiced, and visibly jaundiced, and his bilirubin goes up to 3.5. So what do you do now? Do you operate? CT again, ultrasound, ERCP, MRCP. And we're open for texting. So got an elevated bilirubin 3 days out, after you've been watching him. He's not bleeding, just got a big bilirubin. Got a lot of people who want ERCPM, a fair number of people who want to do ultrasound, a few MRCPs. So, all right, pretty good. Let's go back. So we did the ultrasound first. Not to say that ERCP isn't the right answer, but we did an ultrasound first. And what you see here is a pretty significant amount of fluid here, some debris in the fluid, so not really great. And so then they went and got another CT, and what you see on the CT scan is a lot of fluid. I'm not sure that this added to our care, but that's what they got, and you can see that crack going through the liver, pretty significant injury there. Sorry, that's jumping around a little bit. So we decided to figure out what's in there since there's some debris in there, and we do a paracentesis with a drain, and we see bile. So what do we do now? And we can flip back. Operate, leave a drain and wait, ERCP and stent. I've actually seen fewer people texting when we weren't doing polls than what I'm seeing right now. There we go. Thank you. ERCP and stent. And operate. There we go. Wow, looks like we got a split decision between operate and ERCP and stent. So let's flip back. We did ERCP and stent, and what you see here is our endoscopist, Dr. Mark McCumber, doing a great job of shooting dye up here. This is the gallbladder. This is the cystic duct here. This is the right hepatic duct. There's kind of the left, and then this thing is not really in netter. So that's a pretty significant leak. You see it better there, or see it again there. Put the stent up there, and it's still leaking, but it's certainly improved with the stent. And there it is with the stent in place, kind of showing how the stent sits. They did a sphincterotomy to make sure that the bile can drain freely without developing pressure. So, is there data on this? Well, a little, not a lot, but there is some data. 11 patients that had ERCP with biliary stenting and/or sphincterotomy. None of those patients ultimately required repair or reconstruction of the duct, and they had no long-term complications. The EAST guidelines address this, sort of. So they looked at the data to try and see if they could make a recommendation, and they did come up with level 3 evidence. And level 3 evidence is a recommendation that's supported by available data, but adequate scientific evidence is really lacking. And what they said, and I'll paraphrase here, is that interventional procedures like ERCP, angiography, laparoscopy, percutaneous drainage may be required to manage complications, like this patient has, bile leaks, bilomas, bile peritonitis, abscesses that arise as a result. So their recommendation is that it sometimes may be required, and that's about as strong as they went. But that's what we did. And here we see on the follow-up ERCP that our leak is markedly improved. You don't see that big leak coming. You see the right and left hepatic ducts. You see a little bit of contrast extravasation there from the injection, but overall a pretty significant healing. But then day 9 comes, and now he's got increasing pain and actually has peritonitis, and so you have to make a decision. So here's this patient that we've done a lot of stuff on, and he's got peritonitis. So do you CT and continue non-operative management if there's no free air, or even if there is free air? Do you do a laparotomy, a laparoscopy, or a DPL? So let's see what people want to do now. You've got the bile leak under control, but you have a patient who's not doing phenomenal. So this is one of my partner's cases, so I can be harsh on the management as well. So one of the best things about being the trauma director is being able to look to see what other people did and then be able to criticize them, either justifiably or unjustifiably at times. So a lot of people voting for laparoscopy. So let's go back. That's exactly what we did. So you can see the drain that was left by the interventional radiologist. This is not great looking stuff. I mean, this is kind of nasty. You look at, this is the liver here. I don't know if you guys are used to seeing this, but this is the abdominal wall up here, and this is the liver here, and this is just kind of gras-doux everywhere. So, you have this vision that you're going to go in there, you're going to see stuff that looks like, like a liver, but it's not. After about 9 days, it's just not looking great. So basically the patient got washed out, but isn't doing perfect. Matter of fact, the patient still has nausea, anorexia, and epigastric pain. And so here it is, we've treated the problem, we think, but the patient's not better. And this is a pretty long hospitalization by this point. So, and what you see here is that this patient has a pretty significant rise in their lipase. And the lipase in the fluid that they checked as well from the drain also was significantly elevated. So at this point, we're about a month out, and we get a follow-up CT scan, and it's a good excuse to get the CT scan. And what you see is the liver is looking pretty good. It's actually healing fairly nicely. But now we've got this. You guys know what that is? It's a pancreatic pseudocyst. So this patient had basically a fairly minor grade 2 pancreatic injury, which we had seen on the initial scans, but now has a pancreatic pseudocyst from the injury. So, ultimately, like I said, this is, we do this stuff, and the cases are complicated. We basically ended up doing ERCP, sphincterotomy, biliary stent placement, drain placement by IR, diagnostic laparoscopy, had a PICC line, an NG tube, a chest tube placement twice, which I didn't mention because he developed pleural effusions, ERCP, and the subhepatic drain was finally removed. So basically, we took out both drains on post-injury day 42. He had a lot of pain. He got some acupuncture because we do that, and 52 days in total in the hospital. So grade 5 liver because it's greater than 75% of the lobe. So not clear to me if this is a grade 4 or grade 5. I think we ended up calling it a grade 5. That may have been a little bit generous. Grade 2 pancreatic injury, which ultimately accounted for over a month of his hospitalization, was that grade 2 pancreatic injury, which we pretty much blew off when the patient was first here. Adrenal hematoma was inconsequential. He had a pulmonary contusion. We have a rough time grading pulmonary contusions. We think it's a grade 3 because it's a grade 2 bilateral. Pneumomediastinum, hand fractures, 7 invasive procedures. Basically, his complications were, a delayed diagnosis of pancreatic pseudocyst. We thought that he was having all this problem because of his liver injury, and his, you saw his lipase really wasn't even elevated for a lot of that time that he was struggling. Had some pulmonary effusions. He did have a non-occlusive clot in his portal vein that required some Lovenox, and really this just kind of illustrates that in pediatric trauma, we have some level of evidence. We have a lot of things that we're doing which we try and be evidence-based, but care of this patient requires a lot of individualizations. The algorithms which we have spent years developing help to a point, but luckily as long as teenagers have pranks, we'll have patience. And so at this point, I will actually open it up for questions or discussion. So, which you guys are welcome to play armchair quarterback on this case.
We have a couple questions from the online people. Is there any in the room? No? There's 2 I have here, and then I have one of my own. The first question is, do you use any non-invasive hemoglobin monitoring with the new Maximal, or I believe it's Maximal device, I think. Have you seen that?
Oh, the Massimo.
Massimo,
Yeah,
that's
yeah.
it, thank you.
No, we have not done that, and it's interesting because Steve Moulton is a good friend of mine, and Steve's been talking to me about this device. When we developed the algorithm, this was done with the Atomic Group, which is the Arizona, Texas, Oklahoma, Memphis, Arkansas consortium. We started with the APSA guideline, with the basically just kind of keep them in the bed for grade plus 2, grade plus 1 days in the hospital, and then Arkansas came out with an algorithm that basically said, no, actually use hemodynamic status. And their first decision up here was not, does the surgeon suspect recent or ongoing bleeding? Their first decision was actually, is the patient stable or unstable? At the end of the day, there was no way to define stable and unstable in a pediatric patient without applying some judgment. And as you talk to Steve Moulton, with his device that can do something even better than continuous hemoglobin, which is predict how close you are to failure, you can see that in the future that we may be using CRI as the decision tree as to who's stable and who's unstable, effectively. So.
Very good. The next question is: since you're scanning the head and abdomen anyway, why didn't you just scan the chest?
Principle. The amount of radiation to a pediatric patient for a chest CT is not insignificant. And we try and do the chest CTs only when we have a clear indication. And what we had in this case was pretty much a clear indication that they didn't need a chest CT. So, and then, that abdominal CT from the outside hospital, that was not a chest CT that I showed you. That was just an abdominal CT that went up really high and didn't add anything to the care. So, principle is the answer.
That actually leads into my question. You mentioned that a widened mediastinum is one of your indications, obviously, for CT scan, same in the adult population.
Yes.
But we've found that with the adults, as the population is getting larger and larger, when you do an AP supine chest, you get a magnification effect of the mediastinum, and that can sometimes confound issues. Are you seeing that with the pediatric population in their increased size, or is it not really an issue yet?
As you saw on that chest X-ray, in the pediatric patients, because they're relatively small, we don't have too much trouble getting the beam far away and getting pictures that are not particularly magnified. So we're pretty happy with that, and the plain films are not as much of an issue for us. I can remember, when I took care of adult trauma patients at Grady Hospital, that you had the backboard, you had somebody's pager who fell off, on there, which sometimes was a good, marker for whether or not it was wide. I don't know if you guys remember, but we used to say a widened mediastinum was if it was wider than your pager. Okay. If it's wider than an iPhone 6 Plus. So, we don't have that issue much.